All right, welcome back to the series on headache disorders. In the first video, we covered the primary headache disorders. Moving on to the second part of the video, which will be tackling the secondary headache disorders. So like I said before, 98% of headaches are primary headaches. So that was the migraines, tension or cervicogenic, and trigeminal autonomic cephalalgias. And then the remaining 2% are your secondary headaches. And that's what I will be discussing now. We're going to start by talking about IIH, idiopathic intracranial hypertension. The old term for this disorder used to be called pseudotumor cerebri, because essentially it mimics having a brain tumor, except that there's no tumor. And the idea behind it is the pressure inside the brain is elevated. So that's what we call the intracranial pressure, the ICP. So if this is the brain, you have fluid-filled cavities. These are what we call the ventricles. And then you have fluid also around the brain underneath the envelope, the dura. And the idea behind this condition, IIH, is essentially that the pressure inside the brain is building up. That tends to be seen most commonly in women, specifically in obese women. So those are the top two risk factors for this condition. And the third risk factor for the condition is also specific medications that can put you at risk for IIH. But the bottom line is that you have an increase in the pressure inside the brain. And when that pressure inside the brain increases, it leads to a constellation of headaches. And that leads to blurry vision and what we call papilledema, which is essentially swelling of the optic disc that can be seen on an eye exam. And then it often also leads to whooshing sounds or some kind of intracranial noise. So it can be whooshing, it could be clicking, it could be ringing. So that's a common feature of those headaches. And another important thing is that they tend to be positional. So they get worse if you're lying on your back, especially in the morning, and because that essentially leads to an increase in the pressure because of gravity. Now, how do we diagnose these conditions? So MRI tends to be very useful. First, because we want to make sure that there's no actual mass or tumor. And then two, we get to see sometimes evidence on the MRI that indirectly suggests that this is the condition that the patient has. So things like an empty sella, which essentially means that this part of the brain, which is almost like a collapsible vein, when the pressure is elevated, this one will collapse, and then on an MRI, it looks empty. And so we call that the empty sella sign, and that a lot of times is associated with this condition. However, the gold standard to diagnose it is a lumbar puncture or spinal tap, where basically we measure the pressure, and if that pressure is above, let's say, 25 centimeters of water, then in that case, that diagnoses the condition. Like I alluded to before, this condition involves the eyes and the optic nerves. So very commonly, we will actually send the patient to see ophthalmology or the eye doctors to make sure that there's no swelling of that optic disc, because the most serious complication of the condition is essentially losing vision because of that buildup of pressure in the optic nerve. Treatment for this condition starts with more conservative measures like weight loss. But then if that doesn't work, we start medications that lower pressure. So that will include Diamox. The generic for it is acetazolamide. It's a water pill, a diuretic. But sometimes we use Topamax, topiramate, which also has a similar mechanism. We call a carbonic anhydrase inhibitor mechanism. So those are pretty much the two main medications that we use for the condition. If medications fail, sometimes we have to do several lumbar punctures to get rid of the fluid. And the last resort is surgery. That surgery can either be a shunt, like a VP shunt, a lumbar drain, it could be fenestration on the optic nerve, or it could be stenting in the venous sinuses. So there's more than one way, and a very thorough conversation is usually had with the patient. We just talked about headaches due to increased pressure. So by the same logic, you can also have headaches due to decreased pressure. And we call that condition intracranial hypotension, also known as low pressure headaches, also known as CSF leak. And so the idea behind that is that for some reason, there's a leakage of cerebrospinal fluid that's happening, usually somewhere in the spine. And because of that leakage of fluid, the brain will sag, and that will lead to the headache. That kind of headache will have the opposite pattern of the headache we just talked about, in the sense that it will be orthostatic in nature. So the headache will be much worse when somebody is standing or sitting up, and it will resolve or get much better if they are lying on their back. However, this kind of headache can also be associated with ringing in the ears, vision changes, as well as nausea and vomiting. Now, why would there be a leakage of CSF? So sometimes it could be that the patient had a previous spinal tap a few days prior, or even a surgery in their back that led to a tear in the dura. that wasn't properly repaired. There's a lot of causes, but the bottom line is that fluid pressure inside the brain goes down. This type of headache tends to be difficult to diagnose. It takes sometimes several years for somebody to actually receive the proper diagnosis for it, just because it's rare and also the symptoms are very non-specific. And the treatment for this can involve caffeine initially, the first few days, if it's after a lumbar puncture or a spinal anesthesia, for example. But if that doesn't work, a lot of times a blood patch, an epidural blood patch is needed to seal the hole and prevent more fluid from leaking. All right, moving on. Next up within the category of secondary headaches is a very feared one, brain tumors. So more than 50% of brain tumors are actually metastatic. So they are coming from a source outside of the brain. For example, breast cancer or lung cancer. And less than 50% originate in the brain. So these are things like meningiomas and glioblastoma multiforme, GBM, and other types. However, the bottom line is similar. When you have an extra mass inside the brain, the pressure overall will increase. So you're going to get very similar symptoms to what I discussed with the IIH, such as the headache, the nausea, the vomiting, the vision changes. However, in addition to all of that, you have specific things that only happen if you actually have a structural brain tumor inside the brain. And those will include seizures. So if you have a tumor, for example, right here, it will irritate the cortex around it. That can lead to seizures. Additional things that can happen will be focal deficits. So depending on what part of the brain it's in, it will usually suppress the neurons inside that region. Let's say it's in the part of the brain that controls your right arm. Then by having a tumor in that spot, you're going to have weakness of the right arm. Now, to diagnose it, we need an MRI. A lot of times with contrast dye and other imaging modalities can be needed too, to check the metabolic activity inside the tumor. Treatment for brain tumors will often include steroids to decrease the swelling happening around the tumor. And it will usually include a mix of chemotherapy, radiation, or surgery, depending on the cause of the brain tumor. All right, next up, an equally scary cause of headaches is a brain infection. And that comes in two flavors. You have what we call encephalitis, and that's essentially inflammation and infection of the brain itself. And then you have meningitis, which is infection of the lining, what we call the meninges outside of the brain. And a lot of times the two happen together, so what we call meningoencephalitis. And the idea behind that is that the way it presents is a constellation of headaches, in addition to fever, in addition to neck stiffness, and sometimes behavioral changes, sometimes seizures because of the irritation to the cortex. In broad terms, brain infections can be caused by viruses, such as the herpes viruses. It can be caused by bacteria, or it can be caused by fungi. There are other causes too, but these are the more common ones. And usually the way to work it up is that we would obtain imaging of the brain, a CAT scan, and then an MRI. And then after that, we would do a lumbar puncture, a spinal tap, so that we can analyze the CSF where the brain is swimming, and then send it for microbiology to find out exactly what the organism is so that we can properly treat it with antibiotics or antivirals or antifungals. These conditions tend to have high morbidity and mortality associated with them, as you can expect. Next up in our menu of secondary headaches is Chiari headaches. So a Chiari malformation is when the tonsils of the cerebellum, which is this structure right here, extend below the part of the bone, what we call the foramen magnum, below this part. So if the tonsils of the cerebellum extend below this part, you can imagine that they will basically obstruct the fluid that is passing around the brain, and they will also potentially compress some parts of the brain. Now, there are specific criteria for diagnosing a Chiari on an MRI, but they classically lead to what we call concussive headaches. So these are headaches that worsen when somebody is coughing because of that increase in pressure that happens when you're compressing the cerebellar tonsils against the brainstem, and therefore an increase in pressure. But with time and depending on the severity of the Chiari, you can also have neurologic manifestations as well as dysphagia, so difficulty swallowing, difficulty with the speech, slurring of the speech, and other features of that sort. A lot of times we monitor those Chiari malformations if they are benign or not causing too many symptoms, but if they get worse, sometimes they need to be surgically decompressed. The next one is post-concussive headaches. So post-concussive syndrome in general is what happens after somebody has a concussion. And that concussion can be mild, moderate, or a severe form of traumatic brain injury. But basically, the idea is the same. You have a constellation of headache, memory changes, attention changes, mood changes and sleep as well, and overall fatigue that can happen and brain fog that patients describe. And that can last for months or sometimes even a year or two. And the way we treat it is by decreasing sensory stimulation. So that's an essential part of post-concussive syndrome. And if that doesn't cut it, then usually we would use medications that we borrow from either tension headaches or from migraines, such as amitriptyline, which is a tricyclic antidepressant. All right, the next scary headache that I'm going to discuss is called thunderclap headache. And thunderclap headaches are basically headaches that go from a 0 out of 10 to a 10 out of 10 in the span of 1 minute. So that's a very sudden onset, worst headache of life, pretty much. The most feared reason for thunderclap headaches is what we call a subarachnoid hemorrhage, which is a type of brain bleed that happens when an aneurysm inside the brain, which is an outpouching of the blood vessels right here, if that bursts, that leads to blood in the subarachnoid space. And that is called a subarachnoid hemorrhage, and that has a very high mortality associated with it. Now, in addition to that severe headache, usually patients might have sensitivity to light, they will have neck stiffness, sometimes nausea and vomiting because of that increase in pressure that's happening. When they come to the emergency room, we check a CAT scan that will, a CT head will look for blood. We get vessel imaging to check for the aneurysms. And we also sometimes need a lumbar puncture if we have high suspicion and the CT scan is negative. If we do find an aneurysm, then it needs to be either coiled or clipped. Next up, and along the same lines of brain bleeds, we have different kinds of brain bleeds that lead to headaches. And those include subdural hematomas, epidural hematomas, and intracranial hemorrhages, what we call intralobar hemorrhages. And so the idea behind them is that you have blood accumulation that happens either in the epidural space or the subdural space, or potentially inside the brain itself, what we call lobar hemorrhages. And those can happen due to either trauma, they can happen due to increase in blood pressure, they can happen if somebody is on blood thinners or has a bleeding disorder. In addition to leading to the headache, they will also lead to focal neurological deficits, such as weakness in an arm or a leg, or changes in speech. They can lead to seizures as well, like we saw with the brain tumors. And workup will involve imaging, so CT head, MRIs, and they will often need surgical decompression. However, depending on the case, sometimes we just monitor them and make sure that the blood resorbs. The next category of headaches I want to discuss is a clot that tends to happen in the veins of the brain, what we call the venous sinuses. So you see those structures right here in blue. And if those veins essentially get occluded, that will lead to a backup of blood, because it can no longer drain from the brain, and so that will increase the pressure in the brain and lead to a headache. But it can also lead to seizures, it can lead to stroke-like symptoms, sometimes it will lead to actual blood inside the brain next to where the occlusion is. These are rare conditions. They tend to happen in people who are at a high risk for clotting, such as in pregnancy or right after pregnancy in the postpartum phase. They tend to happen in people who have cancer. So malignancy will make people hypercoagulable, and it will be a risk factor for this condition. We image the brain with an MRI and an MR venogram or a CT venogram to check the veins inside the brain. And then the treatment will usually be a blood thinner. Essentially, this condition is the brain equivalent of a DVT. So you may have heard of a DVT, which is a deep vein thrombosis in the leg. So same thing can happen inside the brain, and we call that venous sinus thrombosis. All right, next up, preeclampsia. So this is a condition that is specific to pregnancy. And specifically within pregnancy, it's second and third trimesters that are at risk. And preeclampsia is essentially the combination of high blood pressure and protein in the urine, or some kind of evidence of end organ damage. And that could be the kidney, it could be the liver, it could be the brain. And a lot of times in preeclampsia, patients will get a headache. And if it progresses to eclampsia, then that means that there's also seizures associated with it. The definitive treatment for this condition is delivery of the baby. However, sometimes it's okay to monitor the pregnancy closely if it's on the milder part of the spectrum. And if there are seizures involved, what we call eclampsia, then we use magnesium for that. All right, next up, I want to talk about sinus headaches. Now, unfortunately, the term sinus headache is really thrown around a lot of times when it's not necessarily a sinus headache. There was several studies that showed that sinus headaches are actually migraines that were misdiagnosed. But a true sinus headache is not that common. It happens when you have inflammation or infection inside the sinuses of the head. And usually it leads to discharges from the nose, so like a pussy discharge from the nose, in addition to the headache. And there are specific criteria for that. We treat it with nasal saline irrigation. Sometimes antibiotics are needed, and we refer to ENT to take a closer look. All right, and the final secondary headache I want to discuss today is called temporal arteritis. The other name for it is giant cell arteritis, GCA. And this is essentially a vasculitis. It's an inflammation of the blood vessels inside the brain and other parts of the body that basically can lead to vision loss. That's one of the most concerning complications of GCA. It tends to happen in people above 50, so very rare to see it in somebody who is less than 50 years of age. And it's associated with an increased inflammatory markers like the ESR would be pretty high. As far as symptoms, patients usually would have a jaw claudication, so pain in their jaw when they are eating, for example, but that's different from TMJ pain. And then they would also have a claudication in their limbs, so pain in a leg, for example, after walking. A hallmark feature of GCA is vision loss. So patients usually get what we call amaurosis fugax, which is a transient monocular vision loss. So vision loss in only one eye that happens for usually about 10 minutes or so. And then the vision would come back, and it's almost like a retinal TIA. But the concern is that if it were to happen again, it can potentially lead to permanent vision loss. The way to diagnose it is usually via lab markers. We initially get lab markers like ESR, sedimentation rate, which is a marker of inflammation, and it tends to be pretty high in this condition. However, the definitive diagnosis usually relies on an ultrasound of the temporal artery, which is this guy right here that you see in red, or a biopsy of that artery to check for vasculitis and inflammation under the microscope. But even before we confirm the diagnosis, if there's a high suspicion, we start high-dose steroids to prevent vision loss. All right, that's it for today. I know this was a lot, and I know it was scary, but these are the important secondary headaches and red flags that you want to watch out for. Again, keep in mind, this is only 2% of all the headaches. So chances are this is not what you have, but these are some of the things you want to look out for and that we look out for as your doctors when you come to the emergency room or to the clinic to make sure that we're not missing a brain tumor or a brain infection or blood. But again, the 98% of people are going to have migraines, tension headaches, cluster headaches. Those are the much more common ones.